everyone. Thanks so much for being here, and thanks Kelsey and Lola for that introduction. As Kelsey and Lola said, I'm going to talk today about treating young people who may be presenting to your early psychosis programs with co-occurring early psychosis and trauma-related disorders. As Kelsey mentioned, I was trained through a HRSA grant at UC Davis Care Center and Psychosis Clinic out in Sacramento, California, where I trained in the treatment of trauma-related disorders as well as early psychosis, and worked with a wonderful group out there on starting to think about and actually put into practice how to treat these two presentations simultaneously. My colleagues out there, especially Don Blacker and Brandy Lyles at the Care Center, and Tara Needham and Laura Tully at the Psychosis Clinic, along with subsequent classes of trainees, have continued this work and have published some really great pieces on it. I don't have any financial conflicts of interest to disclose. So before we get started, I just want to take a little bit of a pause for terminology, because I think trauma can mean a lot of different things to a lot of different people and in a lot of different situations. Primarily, when I am talking about trauma exposure, I'm talking about sort of big T traumas, the way they may be framed in the DSM. And so, you can see on you're right there, kind of a list of some of those common trauma exposures. And, those experiences can happen directly to a person. They can be indirect. They can witness them happening to someone that is a close friend or a family member. They can learn about it happening in detail. And that can happen in personal relationships. I always like to mention it can also happen in professional relationships. So if you're doing this work and you're hearing a lot of details about individuals' trauma exposure, that can also be traumatic in some contexts. A couple of things that we'll touch on in a little bit that don't quite, in an obvious way make this list, but I think are really relevant when we're talking about this population, is that for some individuals, the initial onset of psychosis or experiences that they might have during the initial onset, such as involuntary hospitalizations, arrests, things like that, can also be traumatic. And we can think about where those things might be, right? Like the onset of psychosis and related hospitalization, might fall into the category of a medical trauma or something like that. But I think it's important not just to be thinking about the types of traumatic exposures an individual may have had prior to their onset, but also, the things that they may have experienced in the course of their onset. To talk a little bit about the prevalence of trauma exposure, so about 70% of Americans are exposed to at least one potentially traumatic event. And I say potentially because different people experience experiences differently. What we know is that there are equivalent rates of potential trauma exposures in individuals with early psychosis. So that is also about 70%. And we know that about 30% of people who are exposed to a traumatic event or a potentially traumatic event go on to develop PTSD. What doesn't quite map onto that is that there seems to be higher rates of PTSD in individuals with early psychosis than in the general population. So where the general population, the estimate is about 6.8% of individuals who will experience PTSD in their lifetime. There's been documentation that it's about twice that much in individuals with chronic psychosis, and about 4 times as high in individuals with a first episode of psychosis. There's been some effort in cognitive theory to think about, why individuals who are exposed to a potentially traumatic event might be more likely than others to go on to developing PTSD. And similarly with psychosis, and how, an individual who maybe has PTSD may be more likely to go on to develop psychosis spectrum symptoms or a psychotic disorder. So most people who are exposed to a traumatic event experience intrusions or re-experiencing symptoms in the 30 days after exposure to that event. And so those are things like, recurrent, involuntary, distressing thoughts or images of the traumatic event. It might include intense physical or psychological reactions to reminders of the event. And the idea is that there are, some people may recognize like, well, something really scary just happened to me. And so that's why I'm experiencing this. And that people who go on to develop PTSD are more likely to respond cognitively by interpreting those kind of normative intrusions or re-experiencing symptoms as in negative ways. So they're more likely to interpret them as being evidence of kind of a current or future threat. So not just something threatening that happened to them in the past, but something that continues to pose a threat to them now or in the future, and or as evidence of some permanent negative change that has happened to them. They may then go on to kind of react to those cognitions with negative mood, emotional dysregulation, and cope with that, through avoidance or behavioral dysregulation, which may actually inadvertently increase the kind of intensity or the frequency of the intrusions or the re-experiencing symptoms. And that getting kind of stuck in that cycle may be what contributes to PTSD developing. Some of you may be familiar with sort of the cognitive theories of psychosis, which starts in a similar place. So the idea is that, we all have abnormal perceptual experiences. We all have intrusions into our perception, thinking we heard someone call our name, thinking we see something out of the corner of our eye. Some individuals may be predisposed to having those at higher frequency than others. But the idea is that there's a similar pattern. And so individuals who go on to develop psychosis may be more likely, in the same way we just talked about with PTSD, to interpret those intrusions negatively. And there seems to be, for individuals with PTSD and psychosis, sort of a common negative interpretation around sort of that current or future threat, or kind of those intrusions being evidence of a permanent or negative change. And so if someone already has experience with sort of this cognitive cycle in the context of PTSD, they may be more likely to sort of carry that cognitive cycle into their perceptual experiences as well. So in thinking about, how we might treat individuals who present both with trauma and psychosis in the context of early psychosis care, we started to think about, what are some of the common treatments, and recognizing that there's a lot of overlap in the common components of trauma and psychosis empirically supported treatments. So just to give an example, the trauma treatment that I've been trained in, and we'll talk a little bit more about today, is TFCBT, or trauma-focused cognitive behavioral therapy. And then a common kind of cognitive behavioral treatment for psychosis is CBT for psychosis. Both of those treatments start with psychoeducation. In TFCBT, there's sort of like a skill building and exposure components, which could be thought of as sort of like the cognitive and behavioral interventions that go along with CBT. And then both of those treatments end with sort of, in the context of trauma, we call it safety planning. In the context of psychosis, we often talk about relapse management or relapse prevention. So in the work that's been done out at UC Davis, they have developed a model that is called trauma-informed CPTP. And it was developed and intended to be delivered in the context of coordinated specialty care. And so the model kind of walks through 3 stages of care, thinking about the fact that, I think whether it's the average length of stay or the targeted length of stay in many early psychosis programs is about 2 years. And so how do you kind of tackle the work that needs to be done around, psychosis and trauma-related disorders within that time frame? And so they talk about kind of starting with engagement and coordinated specialty care, followed by kind of targeted, empirically supported treatment, and then kind of moving towards discharge. So I was able to talk with one of the programs that is in attendance today, and think through some of the cases that they're working with currently, so that I could give kind of a case example today that will be relevant. I'll talk a little bit about the case now, and then we can think about where you might go from here with a similar case as we move through the model. So in this case, this is the case of a 19-year-old female who had chronic exposure to domestic violence in the context of maternal alcohol use throughout childhood and adolescence. She experienced symptom onset during the summer after her first year of college, and that started with things like social isolation, hypersomnia, missing work, and progressed sort of over a period of time into sort of expressions of distress, asking for treatment, and kind of progressed further into, the onset of paranoid ideation, auditory hallucinations, some disorganized behavior. And she also was experiencing some suicidal ideation and risky behavior. In sort of the, the later stages of her initial onset, she had gotten lost in an area that was unfamiliar to her, and was arrested and incarcerated for a period of time due to possession of substances. So it's unclear sort of what role substance use may or may not play in this. And then was subsequently involuntarily hospitalized due to the suicidal ideation that she was expressing prior to her referral to an early psychosis program. So, I mean, it's a complicated presentation. She walks in, the way it was described is that, she walks into, a psychiatric hospital and is self-describing as sort of someone who's experienced trauma, and that's sort of at the root of this. But there's a lot happening for this young woman at admission. So we know at this point that, psychosis spectrums are prominent and severe. They've had an impact on functioning. They've resulted in hospitalization. We don't know yet about the prominence or severity of her post-traumatic stress symptoms, but again, she is reporting trauma and is highlighting it as relevant to her current distress and presentation. And so when you get an intake like this, the first thing you're really going to do is focus on stabilization of the psychosis. If she's not yet stable, maybe that's already been stabilized in the context of hospitalization, but maybe not. And I'll kind of move into the different steps in more detail. So again, thinking about stage 1, the focus is really on engaging the client and the family in the coordinated specialty care model. So you're going to start with psychoeducation about psychosis because they're presenting to an early psychosis program. You're going to focus on risk management and safety planning, which may be around psychosis symptoms. It may be around other risk factors, like if substance use is relevant, if suicidal ideation or related behavior is still occurring, kind of understanding that managing that, putting safety plans into place. And all the while, you're going to be doing kind of ongoing assessment and case conceptualization to kind of understand all the factors that are contributing to this young person's presentation. And this is going to last about 3 to 6 months. I think sometimes when these cases present, there's a lot of urgency for the client, for the team, for the family, of like, there's trauma here and we need to do something about it right away. But in order for, you know, the deeper work on that to be successful, you want to make sure that kind of these other factors are relatively stable before you dive into the trauma work. The next stage, stage 2, you know, is really about kind of, you know, the first thing you want to do is you want to determine whether psychosis or trauma-related symptoms are primary or equally distressing. You're going to do that. You know, some of that is going to come from that ongoing assessment and case conceptualization that you've done. You know, you're going to want to really get clear about factors that could impede or enhance treatment. And so that might be some of the risk-related things I talked about in stage 1, but it might also be like family factors. So like in this case, you know, some of the early trauma was in the context of maternal alcohol use, which at intake, mother denied and father acknowledged. And so thinking about, you know, how, you know, each of the, you know, the support people in the person's life are or aren't going to be able to kind of support the trauma work, which we'll get to as we move into the specific model. And you really want to achieve kind of like 1 month of relative stability. So relative stability around, you know, psychosis symptoms, that, you know, they're not having serious impact on distress or functioning day to day, that, you know, suicidal ideation is, you know, relatively stable, substance use, things like that. And then you're going to do kind of a more thorough assessment into PTSD symptoms. So I know that, you know, right now you guys are using a screener that helps kind of get a sense when someone presents to your program, you know, what type of exposures have they had in their life. And that's going to be really helpful because it's going to help you get a sense out of the gate of, you know, whether this is something that you want to consider diving into later or is important to dive into later. But at this stage, you want to be doing kind of a next level assessment of post-traumatic stress symptoms. And so you can do that, you know, through use of the PTSD module of SCADE. Depending on the age of the individual, there's lots of other good assessment measures. The UCLA PTSD Reaction Index, the Child Adolescent Trauma Screen. For adults, there's the PLS-5. So I think, you know, it'll depend, but all of those are going to give you kind of a sense as to what type of specific symptoms is an individual experiencing, and, you know, how clinically significant are they meeting criteria for PTSD, things like that. And then once you've done that, you're going to move towards delivery of targeted empirically supported treatment. And again, depending on, you know, your training and expertise at your specific program, there's lots of different options that are available. There's trauma-focused cognitive behavioral therapy, which, you know, we'll talk about a little bit about today. But there's other models as well, like prolonged exposure, or cognitive processing therapy, things like that. And this, you know, this is going to take some time. You know, it's going to be probably about 12 to 18 months that you'll be in this stage of treatment. And then I don't go much in depth about kind of the third stage. The third stage is going to last about 1 to 3 months and is really focused on discharge and preparing for discharge. So helping connect, you know, folks with community supports, things like that, you know, pretty standard discharge from early psychosis. So I want to pause for a second and just see if there are any questions up to this point.
don't know if this is a question, but more kind of a thought that came to me when you were sharing about the stages. I currently work at First Hope, which is in California. And one of the challenges we see is because of the age group, getting to stage 2, even after, the 6 months can be quite a challenge, in particular when there's substance use. And with the youth that we work with that are, usually high school age, some of them high school age, the sleep definitely makes a difference, and there really is no motivation for change in the sleep patterns or in the substance use. I don't know if that's just something that you have witnessed as well. And what do you do? I mean, we have a substance use counselor, but engaging the youth can be quite a challenge.
Yeah, I think, certainly there are individuals, right, where that, that stabilization is just going to take longer. And I think, depending on, what that, early risk factor is, for example, substance use, and how motivated someone is or isn't to change that, it's going to keep them and the team stuck for a while. And so I think, probably, it's not uncommon that, someone may need more, specialized substance use treatment before they're able to move into this stage. But yeah, it is challenging if it's not able to be stabilized in,
The 6
relatively short period of time.
Yeah, I mean, I think it helps to hear you also normalize the word stuck. Yeah, that's a very common feeling among our team. I mean, we have a wonderful team with it. I'm assuming CSC stands for coordinated specialty care. Is that what? Yeah. So yeah, we have all the resources. I mean, psychiatrists, occupational therapists, peer specialists, education and employment specialists. We have a really nice rounded team. However, if the family, or more than anything, if the client is just not ready for it, yeah, we find ourselves coming to that 2-year for those that are just, in our clinical high risk program, and really not always feeling like we've stabilized, that like we fully stabilized them, I guess.
Yeah, no, absolutely. And that is a really hard spot to be in. I think one thing that's helpful about this model and the fact that it is a staged model is that even if within the time that folks are with you, they don't get to this place, at least it can help, in that discharge process, lay out a roadmap for kind of what work still needs to be done. And, what, setting the stage for, when this piece has been, better stabilized, this is what we would recommend. So I think that can be helpful. Not as satisfying, of course, as doing the work and getting through it, but it's still useful to families. Other questions? So
Casey, one more. I'm sorry. Yeah, you mentioned the screeners for trauma.
Yeah.
Is there a specific one that you use? Because I know you mentioned some for children, some for adults. I don't think we have those in our clinic.
Kelsey, can you remind me what the name of the screener is that you had mentioned? Maybe some of the things they're using.
We are on in Massachusetts, the MAPNET initiative. So we're using the life events checklist, I believe, which is one of those that again is just an endorsement of an experience of an event. They also have in the MAPNET battery, some that assess adverse childhood events, and also traumatic response or traumatic stress response to those. So there are a couple different depending on what specifically you're looking at. But those are what we've used in our network.
And I mostly work with children and adolescents. And so my experience is much more with the CATS, the Child Adolescent Trauma Screen, which is either a caregiver report or a self-report. The UCLA PTSD index I will sometimes use. And what I like about it is that it's done in an interview format. You know, there are pros and cons to both, right? Sometimes individuals are more comfortable writing things down that they're experiencing. But then sometimes you find yourself as a clinician in the dilemma of, now I know something that they told me on a piece of paper, but we haven't actually said it out loud, which can be hard. Versus if you do it in an interview format, you know, the downside is it might be uncomfortable to sit there and talk about it for a while, but at least then you've said it out loud together, and you have sort of a place to move from. So I think there are pros and cons to both. You know, they're both great measures, and depending on the context in which you're using them, you know, they can be helpful in different ways. Both of those are intended up to age 18, and so there's another one called I think it's called the PLS-5. And I have a link at the end of the presentation for a website where you can find that.
Is that the PCL-5? Because I just threw a link, to the MAPNET measures here, and that includes the PCL and the CATS as well.
Sorry about that. Thank you, Kelsey. Perfect.
Yep.
So it's in your chat.
Thank you.
Yeah, of course. So great segue into talking about assessment. So assessment is an important part of stage 2 of TICBTP. And, you know, I just like to highlight some of the important things about assessment. So it's really helpful in determining kind of the role of trauma in a client's clinical presentation. It can be helpful in clarifying kind of the relationship between trauma exposure and psychosis, kind of getting a timeline for how things evolve. It helps, you know, figure out whether an individual has and the severity of their post-traumatic stress symptoms. As I said, there's 70% of Americans are exposed to a traumatic experience or potentially traumatic experience, but only 30% develop PTSD. So even if a person has experienced trauma, it's really helpful to understand how that's affecting them or not at this point in their life. It's helpful in kind of determining the timing of trauma-focused treatment relative to psychosis-focused treatment. And, you know, one of the biggest ways that I use it when I'm doing trauma-focused treatment is it's helpful in monitoring ongoing treatment progress. So, you know, I will often at the start of trauma-focused treatment, you know, give an assessment of PTS symptoms, and then I'll usually do one at the midpoint and one at the end. And it's helpful for, you know, talking with clients and families about, you know, are we on the right track here? And, you know, is this, you know, uncomfortable often stuff that we're doing working and kind of having a meaningful impact on what you're experiencing. So next I'll talk a little bit specifically about trauma-focused cognitive behavioral therapy, or TFCBT. So TFCBT is a gradual exposure model. It has a nice acronym that goes over the different components of it, called, you know, practice. And I always put at the top assessment because, again, I like to highlight that, you know, assessment is really important at the start of trauma-focused treatment. If you just dive into trauma-focused treatment without an assessment, you're kind of going in blind. So it's a gradual exposure model in that from the assessment, you know, you're starting exposure just by asking about experiences and symptoms. You know, I often at that point am really clear with clients that, you know, I'm going to ask you some questions All you have to do is say yes or no. Or all you have to do is tell me, on a 1 to 5 scale, how, or, 0 to 3, whatever, measure you're using, where you fall. You don't want, in the assessment for folks to sort of be giving you a full trauma account, because often they're not ready to be doing that yet. And if folks do that, you want to sort of, be validating. You don't want to sort of send the message of like, oh, we don't talk about that. But you want to set some clear boundaries around like, I really appreciate that you trust me enough to share that with me. And I want to make sure that you're ready before we really dive into that. And so we're just going to start here and we're going to take it slow. So the next step, as you move through the different modules with the skill building components of psychoeducation, relaxation, affect modulation, and cognitive coping, you've got you're gradually increasing kind of the amount of exposure an individual is experiencing, and sort of the intensity of it, moving all the way up to the exposure modules of the trauma narrative and in vivo exposure, which is sort of at the highest piece of exposure. But I think a lot of times people think about like, we're not really doing exposure work until we get to those exposure modules. Really, you're doing exposure all the way through. You're just doing it gradually. So I'll talk with you a little bit about kind of the different components of TFCBT. So the skill building piece, the psychoeducation and skill building pieces are known as the prac skills. The goal of each is different. So for psychoeducation, in the context of TFCBT, the goal is to kind of learn accurate information about trauma and post-traumatic stress symptoms. So it's very common that individuals who have experienced trauma have inaccurate information or interpretations about why a traumatic event happened. A lot of times, those are around, blaming themselves, which, may be just kind of normal human efforts to make sense and get control over experiences that have happened. Sometimes in the case of interpersonal trauma, they've actually been told those things. They've been given inaccurate information about why traumatic things have happened to them. And so at that stage, you're not diving into what has happened to them, but you're providing psychoeducation more generally about what we know about trauma and what we know about post-traumatic stress symptoms and about the trauma they've experienced specifically. And again, thinking about gradual exposure, when I'm doing psychoeducation, I'm often using the words. I'm talking about domestic violence. I'm talking about sexual abuse. I'm talking about car accidents, hurricanes, experiences as a refugee, because using the words and hearing someone else use the words in sort of like a, benignly matter of fact kind of way is a little bit more of exposure, right? The person isn't having to talk about what they've experienced specifically, but they're hearing it and it's starting, right, to stir up some of those thoughts and feelings and memories and things like that, so that you can start to kind of work with how that's feeling for them. Then in this, when you're doing TICBTP, in this phase, you're also normalizing responses to psychosis onset and reinforcing kind of accurate cognitions about what has happened. So giving them information about psychosis, and often in the case where they're presenting together, talking with them, kind of like I did at the start, a little bit about, what we know about how these things tend to hang together, and, how, trauma exposure may have increased their likelihood to develop psychosis. I'll often talk with folks about the stress diathesis model of psychosis in this phase. Okay, so then moving on to skill building, the idea is to sort of teach individuals kind of more adaptive ways to manage their post-traumatic stress symptoms. And so that's usually broken up into 3 different components. So the first is relaxation. The second is affect modulation, and the third is cognitive coping. The goal here is to sort of expose individuals to these skills and get a little bit of practice with using them. They do not have to be a master of relaxation. They do not have to be a master of affect regulation and modulation. You just want to make sure that they've been exposed to the different skills and they've shown some ability to use them, so that if when you get into the exposure components, they start to have an uptick in PTS symptoms, they've got some skill for managing that. So in relaxation, we're developing, 1 to 3 relaxation skills that can be used to reduce physical tension. Sometimes I will use kind of mindfulness skills here. It really depends on the individual, and often the type of exposure, trauma exposure they've had. So some individuals who have experienced interpersonal trauma, it's really disorienting to like close their eyes and do a body scan. For some individuals, that's helpful, but they need to keep their eyes open, or more of a progressive muscle relaxation is more helpful. But I think just being mindful of that is really important when you're going through these skills. For affect modulation, again, you want to make sure the person can sort of accurately identify their emotional state, and develop 1 to 3 skills that can help either reduce emotional arousal or increase positive mood. So we know different people with different people with PTSD have sort of different impact on their mood. Some people have a lot of really intense negative mood or emotion dysregulation. Some people have sort of a dampened ability to experience emotion. So they have more trouble experiencing positive emotions or any emotions. And some people experience both. So kind of understanding, how it's impacted their mood experience, and targeting some affect modulation skills to help them based on that. I'll also sometimes do like SUD ratings so that individuals can learn how to rate the intensity of their emotions. That can be another helpful thing to do at this stage. And then the third piece is cognitive coping. And so that's really about like an introduction to your CBT triangle, right? It's sort of helping them to distinguish between thoughts, feelings, and behaviors, but also about kind of the relationship and the relative changeability of those. So talking about how, your feelings are often related to your thoughts about a situation, not about the situation itself. That, feelings are often hard to change. You can modulate them, but it's really hard to make ourselves not feel a certain way about things. But changing kind of the way we think about it or how we respond to it, or kind of, modulating our feelings about things is usually where we have the most impact. It's really important. It's very common that because you've laid this stage around trauma, that sometimes trauma-related cognitions will come up here. You really don't want to work on sort of restructuring those at this phase. You really want to wait until the exposure phase. So you want to, stick around more things like, if you walked into the cafeteria or you walked into the break room at work and everyone started laughing, how would you feel, right? Sort of like in those more like day-to-day experiences, or, actual day-to-day experiences that they're having, where, they're bothered by situations that are happening and using that as fodder. And again, if trauma-related cognitions are brought up, you want to thank them, for trusting you and sharing that with you, and let them know that you'll talk a little bit more about that in a few more weeks. The reason for that is that sometimes if you try to do some restructuring around trauma-related cognitions at this stage, they won't bring them up when you get to exposure. So if someone has said, for instance, I feel really upset because, I feel like it's my fault that, my dad hit my mom. If you sort of work on like, oh, that's not true at this phase, when you get into the narrative, if that hot thought is still there, they might not raise it because they've already gotten the message that you don't think that's true. And so it still may be there and need a little bit more work. Okay, so moving into the exposure component. So in TFCBT, there are two different exposure components. Generally speaking, everyone gets the trauma narrative or the imaginal exposure, and the in vivo exposure portion is done as needed. So for the trauma narrative, the goal is really to expose clients to details of the traumatic event across all sensory domains in the form of a written narrative. And depending on the age of the client that you're working with, sometimes they're doing the writing, sometimes you're doing the writing. Some individuals prefer to type. If you have a client who feels really, is experiencing paranoia about electronic devices, you probably don't want to be typing out their narrative. So I think thinking about those types of considerations, some individuals are drawing pictures and you're helping them put words to it. So there's lots of different ways to do this. Usually this will start with kind of developing a hierarchy of experiences. So thinking back about the case example that we had, this is a young person who has experienced kind of chronic exposure to domestic violence in the home, and then has had situations of arrest, incarceration, and then involuntary psychiatric hospitalization that they're describing as traumatic. And so you're going to include all of that. For the domestic violence, you're not going to be able to include sort of every account of it. And so often we're asking clients to think about like the first, the worst, and the last as a way to start. And then sometimes there are other sort of really standout experiences that they've had. And, you can include those as well. Then you might include, other things like, the other experiences they had. So, the arrest, their experience when they were incarcerated, their hospitalization. And again, there might be sort of different parts of that are most salient to the client that you're going to want to include. You also want to contextualize this into sort of a broader life narrative, right? So often I will start narratives with like an about me section. I'll often help clients end them with, going to an early psychosis program or starting therapy. We'll include things like, if, what I would want other people to know who have had a similar experience. Because part of this is exposure, but part of this is also meaning making and contextualization of trauma experience. And so once you've made a hierarchy of topics and you've sort of dived in more deeply by either having them write it out or you writing out or drawing pictures and attaching words to it, then you're going to kind of process it with the client. So that's going to mean kind of going over it in detail over and over and sort of helping them monitor kind of the intensity of their, emotional arousal, other types of PTSD symptoms as they do that. You want to get kind of into the nitty-gritty detail. What were you seeing? What did you hear? What could you smell? What did you taste? What did you feel? Because oftentimes those sensory experiences are really deeply tied to the trauma experience and the memory and the reactions. And so you're going to get, you're going to get in real detail until the person can kind of do that and they've really fleshed it out. And sort of the psychological and physical response that they're having to the narrative has gone way down. There's a component of this called conjoint sessions, which essentially once the narrative portion is complete, we'll often work with clients to share that narrative with a non-offending caregiver or support person if you're working with an adult who doesn't have a caregiver that they want to be sharing with. So that could be a partner, it could be a close friend. The reason for that is to sort of have the person have the experience of being able to share their experience, their story with someone they care about who cares about them, and having that story accepted. So oftentimes there's some preparatory work with the support person around like actually reviewing it with the therapist, obviously with your client's permission and awareness, so that they can, sometimes they may have their own reaction, right? So in this case that we were talking about, if mom really isn't able to acknowledge the impact that her substance use has had on her daughter, she's probably not a good person to be doing this piece of the work with. But if dad has some acknowledgement of this and, is willing and is showing that he can be kind of responsive and supportive, he may be a good person to involve in this. But because dad was part of the family too, he may have his own feelings and experiences around this that might make it hard if he heard it sort of the first time in front of his daughter to give her sort of that like supportive, accepting kind of response. And so that's where kind of giving him an opportunity to kind of hear and process it separately before he hears it from his daughter can be really helpful. So that's kind of the narrative and conjoint components. In vivo exposure, like I said, is kind of optional. I have had some cases where of individuals with psychosis who haven't been able to do a trauma narrative, but have done in vivo exposure, especially in higher levels of care settings that I've worked. Again, as like an idea of doing a piece of the work and then sort of, letting them do other pieces of the work later. The idea is that you want to expose the client to non-threatening trauma cues. So, and only when the avoidance of those trauma cues is interfering with self-efficacy or developmentally appropriate functioning. So, for instance, does this young woman have to sort of sit down and hash it out with her mother? No. And say, for instance, you had someone who, within that context, no longer had a relationship with their mother and were avoiding their mother. That doesn't mean they have to sort of go and expose themselves to that. But for this young person, like their arrest occurred in the context of driving at night in an unfamiliar area. And so I don't know, like I have no sense that that's the case for this young woman, but it could be that someone may then develop a fear of driving at night. And if that was the case, that may seriously limit an individual's kind of day-to-day functioning. It might impact, their ability to go on vacations or go out with friends. It might impact their ability to go to work, depending on what their work schedule is like, or, go out of the house certain times of the year when it gets dark earlier. And so that may be something where, gradual exposure, actually doing that, going, may be a useful thing. And so that might include like, driving with other people at night first. It might include, driving when it's like just starting to get dark, right? You want to make sure that they've had some precursor experiences. You don't want to just like put them in the car in the dark. But I think, gradually kind of helping them build up comfort with doing some of those things and helping them manage, some of the experiences that they might be having during that is really helpful. Okay, and then the last component of TFCBT is enhancing safety. And the goal here is to really teach skills that are needed to reduce the risk of victimization, or at least increase the rate of response in case of re-victimization in the future. So we know that individuals who have experienced trauma are more likely, unfortunately, to experience subsequent trauma exposures. And so helping them learn skills that they need to reduce the likelihood that will happen, or at least, increase, their access to services, their access, to social supports, kind of the mobilization of social supports if that were to happen again in the future. And so this can include things like, abuse prevention, for this young person who has witnessed domestic violence, healthy relationship training, or kind of exposure to kind of, understanding of like warning signs of domestic violence, so that she does not herself or is, less likely to experience domestic violence in her own relationships. It might include, things like interpersonal effectiveness training, so that individuals feel comfortable sort of being assertive with others. It can also include things like what to do in case of an emergency, whether that's a physical emergency, a psychiatric emergency. And so in the context of TI-CBTP, you're also going to sort of fold in, relapse management, safety skills, and kind of making clear kind of who safe and trusted supports are for that person that they can go to. This is going to kind of dovetail really nicely into discharge planning, because you're already going to be working on, that relapse management, safety skills, transition plans for ongoing care, identification of support of others, things like that. I want to open it up again for questions. I think we've got quite a bit of time left. I'm happy to hear any comments or questions you may have.
I just want to start out, Casey, by saying thank you so much for this. I think that this can feel really complex, and this is such a clear, straightforward set of, steps and activities. So I really appreciate, all of the work that you've done on this, and also your coming and sharing it with us. One thing that came up for me just as you're talking is, so specifically thinking about this overlap of trauma and psychosis, those cases where somebody's trauma is a direct byproduct of, their psychosis, whether it's from their delusion that they have that was experienced as traumatic to them or something along those lines. So how do you approach things like that?
Yeah, I think the topic of sort of trauma experience plus delusions is really complicated. It's not uncommon that there can be trauma related content embedded in delusions. As you're saying, sometimes individuals have, their symptoms themselves, and the experience of that has been traumatic for them. I think, I would probably, again, kind of frame that as, a medical trauma, and sort of talking with them about, kind of what it's like for individuals who have had sort of scary medical experiences, and really framing it that way. I think it will help from the perspective of kind of moving towards kind of an accurate understanding of psychosis and what they've experienced, but also can be really validating. I think that's what you're getting at, Kelsey, but if there's more to it that you're asking, let me know.
No, I think that covers it. It also strikes me that, the treatment that they get from the psychosis clinic specific to those symptoms is really a part of that last point, the enhancing safety. So hoping that they don't have to re-experience those things. But yeah, thank you.
Yeah. And I think like there's this idea, right, that like obviously reality matters, right? But a person's experience of their reality is also valid. And so I think we don't want to collude with a loss of insight in the sense of like, no, that really did happen to you. But we do want to kind of, validate and honor the fact that like their experience of that really happened to them, and help them as best they can kind of separate out, what did or didn't happen from how they felt about it and how they experienced it, right? Like if you had a fear response to a snake moving through the grass and then came to find out that the snake was actually a hose, it's a hose, not a snake, but your experience was the same. Your fear reaction was the same. And so I think when we're doing trauma work, obviously we want to be being accurate as best we can about what happened, but we also want to be tending to the fear response or, whatever emotional response the person had. Does that make sense?
Yeah, absolutely.
Other questions or comments? And I know after several years of Zoom talks, like it can be scary to unmute yourself and say things out loud. You're welcome to type things in the chat, and I can answer them from there too.
Well, and I know you had said there are a few resources. There are some questions around screening tools and those kinds of resources.
Yeah, so I think Kelsey put some assessment batteries in the chat, which is awesome. On the next slide here, I've got some other links there. So some information about TFCBT more in depth. So there's the TFCBT web is a great resource to know about if you haven't already done that. So it's a 10-hour training, like it counts for 10 hours of CBUs. It's free, which is really cool, and gives sort of more in-depth training on TFCBT as a model. It is traditionally done for, used with children and adolescents, but it is also the treatment that was sort of the foundation of TICBT. So I think, as you're moving through that module, cases may, you may have to think about how you would scale up some of the interventions for development. But I think it's still a great place to start. And then there's some books on it as well. The National Child Traumatic Stress Network is a fantastic website. They have a lot of really wonderful resources on that can help with psychoeducation around specific traumas. So you can actually go to a specific trauma that someone has experienced and get information on like the frequency with which that happens, common reactions to it, things like that, that can be really helpful around normalizing kind of trauma, normalizing having had a trauma experience. Obviously, we don't want to say like, it's no big deal that happened to you. But like, there are other people who have experienced that, I think can be really empowering. Because I think a lot of people feel alone in their experiences. And also normalizing some of the reactions that they may have had to it. And then for adults, the US Department of Veteran Affairs has a lot of really great resources, including around assessment and treatment tools. They've really come a long way. I know when I started giving these kinds of talks, it was very veteran focused in the sense of, talking almost exclusively about combat related trauma. And their website, they've added so many more resources around, interpersonal trauma, kind of other types of traumas that individuals may experience. And so it's a really good resource. Don't let the title scare you away. And then again, going back to before, the Folk et al. Article, Uncharted Waters, is a really great resource. So it describes this model in a lot more detail, including some preliminary data on effectiveness of it. And they have some really great supplementary materials that go through specific cases. So I think it can be a really helpful reference for someone who's looking to do some of this work.
Could you repeat that again? I missed the first part of what you just finished saying, the title of it.
Uncharted Waters.
Oh, Uncharted Waters. Is that a book?
The start. No, it's an article, and it's an open access article, which is great. Let me see if I can go back. Oh no.
Oh, sorry. It's okay.
All right, folks.
Will it be in the handouts that you send out?
Sorry, hold on 1 second. Now you can see the presentation. Is that right?
Yep. Yeah, it's coming out.
So it's this one here, Uncharted Waters, Treating Trauma Symptoms in the Context of Early Psychosis. And it's an open access article, so you can find it on the web.
We have another question in the chat here. Do you have recommendations on working with first episode of Psychosis events that require crisis intervention?
I feel like I need more detail about what part of that.
Sure. Ashley, do you want to expand on that at all? I would imagine the question has to do with trauma around crisis intervention, but we'll let Ashley clarify. Might not be on anymore. Sorry.
That's okay. I assume she might mean like things like, you know, involuntary hospitalizations, restraints, things like that. And I think, you know, I think similarly to what we were talking about around delusions, you know, some combination of, you know, recognizing, you know, that as, you know, assuming, I will say to start, assuming that it seems that those went as they should given the circumstances, that kind of the response, even if it was traumatic to the individual, was, you know, according to best practice, was really necessary for what was happening. I think, you know, helping them, you know, frame that as sort of, you know, a really distressing medical intervention that needed to happen or did happen. I think if that's not the case, though, then I think, you know, you're almost sort of more treading into, you know, more of the, you know, in, you know, if they were isolated for long periods of time, if they were, you know, restrained in a prolonged manner or an aggressive manner, I think maybe kind of looking more towards kind of the neglect and physical assaults literature might be helpful in, you know, helping validate and normalize some of the experiences that someone might have. I think honestly, there isn't a lot of literature around that at this point, as far as I know, like how I'm sort of pulling right from different areas in how I would think about it. But I think, yeah, I think that's where I would go. I don't think there's a lot of like clear, you know, in this context, this is what you should do. But I think it's a place where there's a lot more needed kind of information and support, because again, it's not obvious on that list of, you know, traumatic events, but I think it's something that's very frequently endorsed and very frequently experienced. And again,
Yeah,
you know, really tending to that person's experience is important.
Great. Another question from Sasha Guzman. How soon after an event could you begin this treatment, and what kind of stability should people have before starting? I know you had a little bit to say on that, but can you expand on that?
Yeah, absolutely. So I think, you know, again, so how soon after an event? So I think, you know, that makes me think about, you know, say there's someone already in a program who has experienced a traumatic event. You know, I think the same guidance around you want kind of at least 1 month of stability is really important. I think you want to make sure that the event isn't ongoing. It's very hard to do trauma work or, you know, really impossible to do trauma work when someone is in the midst of a traumatic experience. So you want to make sure as best as possible that that has stopped happening. And, you know, that may be part of that kind of pre-stage 2 stabilization that you're doing, right? Of like helping make sure that, you know, they have, you know, they've established some safety. But I think, you know, the general guidance is about a month of stability. And then of course, you know, we know that some of these experiences like, you know, intrusion symptoms, re-experiencing symptoms are very normal in the first month afterwards. So generally when we're talking about PTSD, you know, an acute stress disorder is thought of as sort of like in, you know, the immediate wake. And then, so like 1 to 3 months, I think it is, And then PTSD is really more, like 3 to 6 months after exposure, is when we would start to make that sort of diagnosis. I think that's correct, with the current diagnostic criteria. But I think making sure that enough time has passed for folks to move out of maybe like a normal reaction to trauma, or an expectable reaction to trauma, before kind of diving in with trauma-focused treatment.
Right. And sort of, so to build on that, are there parts of this that you would recommend for that period where somebody is in that kind of normal or expected reaction to trauma, very, shortly after an event?
Yeah, I mean, it's a good question. I'm a little bit less experienced with like a trauma first aid type work, but I think, that literature does exist and might be a good thing to reference. I think, normalization, psychoeducation, that's not going to hurt anyone. And helping them think about like, how, just kind of, how they're feeling, checking in about how they're feeling about it, how they're responding to it. If it's very clear, in those 30 days that they're, doing major avoidance or things like that, helping them think about and consider, when they might be ready to start to kind of ease back into some of the, the healthy, kind of expectable day-to-day things. But I would be very gentle in that piece.
Can I ask something? Yeah. I was curious, you said something that kind of struck me, and for some reason I'm like, duh, like I realized I should know this, but I was wondering if you could give a little more examples based on your experience. You mentioned that when introducing like relaxation, skills, someone with interpersonal trauma will most likely not be able to close their eyes and kind of do meditation. So I believe you mentioned maybe you try progressive muscle relaxation instead. And so I was wondering if you could elaborate a little bit more on maybe some other things to consider when applying this, because I right away had a flash of all my clients and kind of looking at which ones have the hard time. There's some that just can't even, not for 30 seconds, can get into their body, right? And I know that they had a lot of physical and emotional abuse as children, right? So yeah, just kind of wanting to pick your brain a little bit on what to watch out for.
Absolutely. Yeah. I mean, I think it's a really important piece, right? Like for a lot of individuals, whether it's, physical abuse, sexual abuse, certainly, sometimes emotional or psychological abuse, the body isn't experienced as a safe place. And so, often, regardless of type of exposure, some of my go-tos are often, diaphragmatic breathing, progressive muscle relaxation, if they can do that. And sometimes that's like, it matters where you're focusing on it, right? Like maybe they can, thinking with them about like, do you experience physical tension and where is that? And working a little bit more localized, as opposed to like doing a guided body scan that goes over every single body part, which might be a little bit harder to tolerate. Again, kind of giving them permission to keep their eyes open or close their eyes, depending on what's most comfortable to them. I think sometimes, sitting instead of laying down doing those things can be more helpful or less. I think trying to think what, some other good ones are. Again, guided imagery is one if someone can tolerate it, but again, that may not be relevant to this case. I think sometimes like mindful walking or mindful eating can be other really helpful ones that kind of slow people down and bring that kind of mindfulness and sometimes, some connection with the body that's a little bit easier to tolerate. So, just thinking about like, walking, one, my heel hits the ground, the middle of my foot hits the ground, my toes hit the ground, my other foot lifts up, right? Like sometimes that can feel a little bit more tolerable, but is still kind of going to center them, relax them, help them be more present. And same thing with eating. You know, it's fun to bring in like oranges and dark chocolate and get different sensations, you know, assuming we can do that these days. Or have them do it on their own and talk with you about it.
Thank you.
Always get questions.
Mhm.
My email information is on the slide.
Great. Great. Well, if that is everything, thank you everybody for coming. We'll follow up over email, but otherwise enjoy the rest of your Fridays.